Welcome to the DaVinci Hour, a podcast series that interviews individuals across the field of medicine to help provide an inside look into their experiences and provide insight on how to navigate the journey of becoming a physician. My name is Dr. Maxwell Cooper, and I will be your host. This podcast is brought to you by DaVinci Academy, a medical education company that provides online video courses, outline format books, and clinical case videos for students studying the medical basic sciences. You can check out all that DaVinci Academy has to offer at www.dviacademy.com.
All right, everybody, welcome back to the DaVinci Hour podcast. I am joined by Dr. Susan Kimmel this week, an attending psychiatrist. Susan, thanks for coming on the program. I really appreciate it.
I'm happy to do it.
Awesome. Maybe could you give the listeners a little bit of background on your, where you went to med school and did your training and kind of where you are today?
Absolutely. So I went to medical school at the Medical College of Ohio, which is now University of Toledo, which is in Toledo, Ohio. And then after that, I did my residency in psychiatry at the Cleveland Clinic and was there for 4 years. And after I finished at the clinic, I took a job where I am interestingly still at, although I've had several different renditions of what I have done. But I went to University Hospitals of Cleveland, and I've been at University Hospitals for a little over, I would say, 30 years at this point. So a long time, done multiple different things there, but really have sort of stayed within the same system. In 2010, I went back and I actually did a fellowship in forensic psychiatry. So I felt like at that time I was interested in learning more, doing something a little bit different than what I'd been doing. So, even though you've picked a certain path, you can always broaden that or get interested in other things. So I changed and did that fellowship, which I thought was really a lot of fun and an interesting perspective after having been an attending and teaching residents and medical students to go back and kind of be the learner. It was kind of a breath of fresh air. So I was pretty happy with that.
Interesting. Yeah, I imagine that's quite a transition to go from being an attending for a certain amount of time and then go back to kind of square one, if you will, in a certain area.
It was. I think it's different being a fellow than it would be if I was going to do a residency in something else. One of the other things is, although I would say it was a fair amount of work, it was a lot of written work. So a lot of those reports that you would do as a forensic psychiatrist, you did at home at night. There was no call involved. So there were some things that might have made me think I could not do it, but those have been call or, just longer hours, and there were long hours, but a lot of it you sort of did at home and a lot of it was writing.
Interesting. Now, just for the listeners, I actually rotated on a forensic psychiatry rotation in med school, so I'm familiar, but maybe for people who aren't familiar, maybe could you elaborate on what forensic psychiatry entails?
Yes. So forensic psychiatry is the interface of psychiatry and the law. And it sort of it's kind of in a broad stroke, I would say that there's sort of two different divisions kind of within forensic psychiatry. So there's a civil division that often has more to do with like workman's comp cases or insurance claims, disability claims, whether people have the capacity to execute a will. So that's called testamentary capacity. So there is a big civil piece, and then there's more of a criminal piece. And I think that's what people think about when they think about forensic psychiatry, or they see somebody on Law and Order who's testifying as the psychiatrist. And those, the criminal side then would be, it would include treatment of inmates within a correctional setting. It would include competency to stand trial reports. So that's a here and now evaluation of an individual or a defendant, whether they have the capacity to understand the nature and objectives of like the legal proceedings against them, and to assist counsel in their defense, so that we don't take anybody to court or put them on trial who doesn't understand really the proceedings and what's going on. The other report that we commonly do would be not guilty by reason of insanity. Those are people at the time of the crime really didn't understand what they were doing essentially is wrong. So there is a big criminal side to it. Most forensic psychiatrists, or I shouldn't say, but a lot of forensic psychiatrists think that criminal part is the more interesting part. Why people do what they do, methods to sort of protect the mentally ill who have committed a crime but don't really understand what they're doing. And then those individuals, at least within, it's usually state by state, but in Ohio, if you're found not guilty by reason of insanity, then you are often sentenced, not sentenced, but you're sent on like a commitment to the state psychiatric hospital. And there's lots of safeguards before those individuals are released from the state sort of mental health system. And it probably varies state by state. Obviously, I'm in Ohio because that's where I live and am very familiar with what we do here, but it could be a little different in other states. But it's not that people just walk out of jail once they're adjudicated not guilty by reason of insanity. They usually are sent to a hospital, and then there's usually several people who have to agree to move them to a less restrictive environment, like a 24-hour supervised group home.
Gotcha. Yeah. And would part of that also entail, like, do you testify in court frequently for that, or is that kind of a separate thing?
So you can. So on the civil side, you can be called in on any of things like malpractice would also be something that I would consider a forensic psychiatry specialist. So we sort of also would look at malpractice suits, both from the defense side as well as from the plaintiff side. And you could be called in to testify on pretty much any case you work on. Oftentimes, the two parties, the prosecutor and the defense attorney, will agree and stipulate to the report. In other words, they'll just accept the report that you've submitted. If there's questions or concerns, they can definitely call you in to testify in really any case that you've done.
Gotcha. Okay. And is that a year-long fellowship that typically that people would do for that? Okay.
Yeah, it's 1 year.
Interesting. And is most of that inpatient work, or is there an outpatient component to that as well?
So forensics would mostly, I guess you would consider it more outpatient, because, or there are forensic psychiatrists who, for example, work in the state psychiatric hospital. So if the judge decides that the defendant is not competent to stand trial, based on the report that they're going to get either, and it's not always a psychiatrist, sometimes it's a psychologist who also sort of authors these reports. But if the judge makes that determination, looks at our report, agrees with what we've opined in terms of the opinion, and have decided that they're not competent, they'll go to the state hospital for something called competency restoration. So they will get both mental health treatment, and as well as they'll go to classes where they learn sort of pretty basic things, but a lot of things about courtroom procedures, make sure that they understand if they're offered a plea bargain, what that means, that they're making rational and logical choices when they're given plea bargain options. So there's a lot of forensic psychiatrists who then work within, like, as on the inpatient unit on like a competency restoration unit. And so those would be forensic psychiatrists as well. Most of the court reports, the competency to stand trial not guilty by reason of insanity being the most common ones, those we usually work in something called ours is a court psychiatric clinic, but most places have what they call a forensic center or a court clinic, where the inmates or the defendants are brought over for the evaluation. So in Cuyahoga County, the inmates are brought over to the offices, which are housed in the same building, for us to evaluate them. In Summit County, there's a group that actually goes to the jail that does those evaluations. So it's a little different, probably county by county, depending on how big the county is and what kind of volume they have. But most places will have a court clinic. We can also do evaluations in that setting. In bigger counties, they're going to have a mental health court. So they're going to have a subset of the judges who are specially trained to understand mental health issues and intellectual disabilities, and how that might be not the factor, but a factor in the charges that the individual has. So there are judges who are specially trained. And so we'll sometimes do an evaluation about eligibility for transfer to the mental health docket, which means they're going to get one of those judges who has special training in that area.
Gotcha. Now forgive me if this question seems trivial, but there's kind of a lot of craze in the media these days of, these shows where you show like FBI profilers or people that, profile criminals psychologically or anything. Is that something that a forensic psychiatrist would participate in, or is that something more like a clinical psychologist or someone in law enforcement would be more involved with?
We do not necessarily have special training in profiling criminals. And so that probably falls more like within the FBI. I know they have special behavioral individuals who just sort of study those kinds of things and try to work up profiles. But I would not, at least in our fellowship, that was not anything that we specifically looked at.
Gotcha. Interesting. It's really fascinating that intersection of, like you said, the legal system, using your medical training, and then kind of it's very different than kind of what I think some other kind of the mainstream focus of medicine, which is pretty cool. Is this what you do 100% of the time, or how, if not, how do you devote, what other areas of psychiatry do you work in, or have you worked in the past?
So I would say it is definitely not 100% of what I do. I would say that the information that you learned during that fellowship, lawyers are very careful with their words. So I think it's made me much more careful when I write clinical notes about the words that I'm using and how that might be interpreted differently by different people. So I think that that's helpful. I have a few private cases. So every once in a while, somebody will reach out. You can, accept those cases or say no to those, depending on how busy you are. At the moment, I have very many private cases. I'm pretty busy sort of doing what I do most of the time. I spend a half a day at the court psychiatric clinic in Cuyahoga County. And that definitely relates directly to the fellowship. And then I spend 2.5 days treating inmates in a jail. And so I work in Summit County Jail, but that also, and that's not doing special evaluations, that's just treatment, because they are confined and they can't go out to see their psychiatrist or be evaluated. Then we'll see them for treatment. Some of them, depending on how severely ill they are, if they're extremely psychotic and they're really not eating, not drinking, too disorganized to sort of manage, we can also send them to we have to have the judge agree, but we can send them to the state psychiatric hospital on like a civil admission, just like anybody else would go. They wouldn't be a forensic person there for competency restoration or a not guilty by reason of insanity acquittee, but they would go just as a civil admission. And then when they're improved and they're treated, then they'll send them back to the jail and then they can go to court.
Gotcha.
They tend to not stay as long in a civil admission. So I think what most people are going to see during medical school is our average length of stay is 5 to 7 days. But to be restored to competency, those people, you're limited about the charges. So you can't have stolen $5 and end up being in the state psychiatric hospital for 3 years for competency. Right. Some people are going to be unrestorable. So depending on what level of a crime it is, whether it's a misdemeanor or a felony, depends on how long you can actually keep them in the state psychiatric hospital. So, but typically to go for competency restoration, it's going to be a longer inpatient hospitalization than what you would normally see during medical school. So my day, so half of what I do, sort of a half a day every week, Monday through Friday, is inpatient. So I'm on the inpatient unit that is associated with Cleveland Medical Center or University Hospital, sort of the Cleveland campus, kind of the main campus. There's 4 psychiatrists who are on that floor. So we sort of divide up the patients evenly. So half of what I see is inpatient. And then every half day is a little different. One half day, I am at John Carroll when I do sort of college mental health. I've also was at Case doing college mental health in the counseling center for 10 years. And like I said earlier, 2 of the other half days, I'm at Summit County Jail providing treatment. 1 half day, I'm at the court psychiatric clinic, and the other half day, I do ECT. And now that's branched out to be ECT and ketamine infusions, and now the new S-ketamine, nasal ketamine.
Oh, wow. So yeah, you have a very diverse practice, which I think is pretty interesting. I imagine that's probably what attracted to you in some way, is that you're never doing like the same thing over and over again, which is, we were kind of talking about that before we started recording. I imagine that keeps you sharp and keeps you interested.
I like the variety. Not everybody does. So I think you have to take the good with the bad and figure out what fits for you. So some people might do like a half a day inpatient and the rest of the time be in the same office seeing outpatients. I'd rather mix it up. I like to move around. I like to see different things. I think it's interesting. And otherwise, I've done more outpatient in the past. It hasn't necessarily, I liked it, but I felt like it was a little draining all the time. So this is just what I like, but I think that's very individual specific.
Gotcha.
We're going to take a quick break to let you know the DaVinci Hour podcast is brought to you by DaVinci Academy, which provides online video courses for the medical basic sciences. These courses are taught using a variety of teaching methods, including bullet point outlines, diagrams, radiology images, and chalk talks to explain the fundamental concepts. We then teach the application of those concepts to numerous clinical pearls that are frequently tested on medical school exams and the USMLE. Our video courses are available on our website, dviacademy.com, as monthly subscriptions starting at $9.99 per month. Each video course has a corresponding outline format textbook as well. You can find the link to our website in the description below. Also, be sure to use the discount code TDH20 to receive 20% off any of our video courses. All right, now back to the podcast.
Now, is inpatient psychiatry, is it, in comparison to outpatient, is it analogous to like internal medicine, for example, where inpatient medicine can be a little bit more high acuity, more unpredictable, maybe longer hours, versus like outpatient medicine's more, predictable. The patients are relatively controlled, you're just kind of maintaining things. Would that be a fair comparison, or is it a little different in psychiatry?
I think it's a little different in psychiatry because because there's 4 of us, things sort of get divided at the beginning of the day relatively evenly. So you have a relative idea how many patients you're going to have sort of across the board. That doesn't change much. It takes a little more time on a new patient than an old one, but you also, you don't have the crises, like the medical crises, somebody gets very sick very rapidly.
Mm-hmm.
And it's an emergency. So I think that those things are a little different in inpatient. I feel like it's pretty regular. You can typically do your work and the time, the time you have set aside, which just depends on, what your average caseload is going to be. But I don't feel like it runs over like inpatient internal medicine. So I don't think it's a whole lot different than outpatient. When I did outpatient, I felt that could run over more because there were more phone calls. There were, like, from the patients, there were more phone calls. You had more prior authorizations for like medications. If you had somebody that needed to be hospitalized, there went your day, like there went your afternoon. You would have to call security. You have to, it's a little different than an internal medicine person. You can say, oh, just take yourself to the emergency room, and you can assume they're going to do it. If you have a suicidal patient in your office, you can't just let them go unaccompanied. So then you got to call security. You got to get a ride. You got to get them to the emergency room. So I kind of felt like that was harder. I don't know that everybody would feel like that, but for me specifically, I felt like that could really lengthen out your day.
Gotcha. Now, is your practice academic in some ways? Do you work with medical students and residents, or is it more of like a hybrid where you do a little bit of private practice as well?
Right. This is all, so the inpatient side is all academic. There are residents always, unless they're on vacation. There are residents always on the unit. And so it's a 1-to-1 ratio, 1 resident for 1 attending. And then medical students, it's a little variable. Typically, we have one medical student on the team. This month or this 2 weeks, I have two because I have an acting intern. So I have a fourth year and I also have a third year. So it varies a little bit depending on the month, but typically you'd have a medical student and a resident.
Gotcha. Okay. And I guess from the pathology side of things, it sounds like in many ways, you see the full gamut of psychiatric issues. Is that fair to say, or is there one particular area you focus on, or is it kind of the full gamut, would you say?
I would say it's the full gamut. I think in terms of it's going to be more of the severely mentally ill that we're going to get in the hospital. Just insurance companies don't just let you admit anybody. So you're going to see more people who are psychotic or schizophrenic. We're going to see people with mood disorders, but they're either going to be so depressed that they're typically suicidal or they're very manic. So you're going to see people who are relatively sick compared to what you might see in an outpatient population. Once they get better, then they're going to be transitioned as fast as we can back to the outpatient side. Psychiatry has come up with, partial hospitalization programs and intensive outpatient programs to sort of step them down a little bit.
Mm-hmm.
But we do see a sicker patient population than you're going to see on the outpatient side.
Gotcha. And I think one thing that I learned very quickly last year, because I did an intern year where 80% of it was at a county hospital, similar to, Metro Health in Cleveland, here, where we dealt with a lot of medically complex patients, but also a lot of patients with complex psychiatric issues as well. And I remember it was always a matter of having to get them medically stabilized before they could get, the full psychiatric treatment if they needed, inpatient versus outpatient. Is that fair to say at most places where you're not really, you're not going to manage somebody unless it's like something of life or death, until they're medically stabilized. Is that fair to say?
Yes, absolutely.
Okay.
So we go through, always different iterations of what we need in terms of medical clearance, but they do need to be medically cleared because we just don't have access. The psychiatry sometimes takes a fair amount of room. So some places like university hospitals, Cleveland Clinic is the same way. They have put the inpatient psychiatry off of sort of the main campus. So even though we're still considered main campus, we're not located there. And we do have a med psych unit that is smaller, that is at main campus, but we just don't have the same kind of medical backup that you would have if you were downtown where the bigger hospital is. There's also, not just us, but there's some also just freestanding like psychiatric hospitals, and they have, somebody like an intern nurse who might come in and do the initial history and physical or take any kind of consults that you might have, but you wouldn't have in those places, you're not going to have access to like an MRI if you want it, or other medical tests. So you really have to be pretty sure that they're medically stable before we take them.
Gotcha. Okay. So I guess on the inpatient side of things, maybe take us through just like your typical day for that. I imagine you probably do rounds and probably do, I guess, obviously it's a mix of probably evaluating new and older patients. Do you guys take turns who's admitting for the day or things like that? Or I guess how does that all kind of run?
So the admissions that come in overnight are divided up in the morning. So we know who's new in the morning. We try to keep those if like my resident admitted them, the resident is working with me on my team at the moment, we try to keep it with the resident to the best of our ability. Those get divided up in the morning. And then the new admissions get seen the next day by us. So the resident or the resident that's on call, currently we're doing a night float system. So a resident will have already seen them, but we probably won't see them until the next day is the typical schedule for the new folks. We go in, I probably start most days around 8, somewhere between 8 and 8:30. And we will go around and sort of go over what happened overnight. And then we'll go round with the resident, the medical student, and sort of see the patients. And typically we're done by 11:30 or 12. Then I'll need to go and sign, there's always sign notes, they need a back to work slip. Our patients, not all of them want to be in the hospital voluntarily. So some of them have to be civilly committed. So on those individuals, sometimes you'll have a hearing. They used to be in person. So pre-COVID, there's a attorney for the patient. There's an attorney from the board who represents like us. And then there's a magistrate that serves as the judge. And those hearings the magistrate will make the decision. So if the patient wants to leave and I really feel like they need to stay, we'll have a hearing. The magistrate will make that decision about whether they stay in the hospital or whether they leave. So that would be thrown in there. In any particular day, you might have a hearing. Usually we know of those ahead of time. So you can, that could take, if you're going forward with the hearing, that could take 20 to 30 minutes.
Gotcha. Okay. And then those days when you are doing the more of your kind of wearing your forensic psychiatry hat, are those days, are you typically flying solo, or do you have residents that come with you at those times? Or, and I guess, how does that, do you kind of do your rounds in a sense, similar to how you would in the inpatient unit on those days?
So at the jail, there's a nurse, there's a dedicated behavioral health nurse who rounds with me. So we'll have a list of patients. It's a little bit of a wish list because it's always a really long list because there's more patients in the correctional setting than we can sort of manage easily. So there's usually a long list. We see who we tried to prioritize, who's not on medication and who came in, who's a new evaluation, anybody that we know is specifically having trouble that we've heard either from the deputies or from the medical nurses or the counselors who are sort of seeing them routinely. So the nurse will sort of round with me, and we see as many people as we can in the time we have allotted. I don't, unless I have somebody shadowing. A lot of people are interested for some reason in correctional psychiatry. So sometimes I have a medical student or a resident who's really sort of interested in that patient population and really wants to come. So sometimes we'll have people shadow us and they will come with us and just basically observe. The forensic psychiatry fellows need to have a correctional psychiatry experience. So we have a forensic psychiatry fellow who is there as well. They are, though, they're at a different time than I am. So because you're really board eligible at that point, some of them get board certified during that fellowship because that's when they took their exam. They can see their own patients just with supervision. And so they come at a different time, have their own individual caseload that they follow just like I do. So we don't necessarily intersect, with the exception of supervision for them. And Dr. Bodner, a different psychiatrist, has taken that over this year from me. And then at John Carroll, where I do student health, I usually have a resident there with me as well. So once you do your first 2 years in psychiatry, it's a lot of inpatient work, internal medicine, neurology, consultation liaison. But by the time you get to your third and fourth year, it's more outpatient. So it's an elective. John Carroll is an elective, doing student counseling at cases an elective. So that's up to them. But I inevitably have a resident who's there. The resident is also seeing their own patients while they're there. And then we have the last hour of the day for supervision to go over things, but we're always there at the same time. So if there's any questions between patients, we can also address those.
Gotcha. And then when you're working at, at these university settings, whether it's at Case Western or John Carroll University, is that more of an outpatient, or are those patients, do they kind of come in as an as needed basis, or are these patients that you more follow on over a long period of time? I guess maybe kind of walk us through that aspect of your work.
Those are undergraduate and graduate students who are enrolled in the university who are having, it can be the whole gamut of mental health problems, but it is outpatient. So there's psychologists and social workers who also do like psychotherapy. counseling with the students. If they feel like they would benefit from a medication, they'll refer them to us for an evaluation, and then we'll do just like you would in a normal outpatient setting. It is almost by design, because you either graduate in 4 years or 5 years, or you decide to leave and do something else. It is by design sort of a shorter term model, I guess I would say. It's not like you're going to follow somebody for 20 years. So it's a little shorter term. The age of the population is also sort of what we call transitional age these days, but usually between 18 and 26-ish. And at Case, Case is an interesting university because it's kind of half undergrad, half graduate students. So, and we would have the medical students, the law students, sort of the whole range, PhD students, people there who might just be getting might be doing like an MBA. So they're just there for 2 years. So it was quite a range. It's a little different in Case. John Carroll's obviously smaller.
Gotcha. And you mentioned a little bit of the difference between a psychiatrist and then, say, a clinical psychologist. Could you maybe expand on that just a little bit? Because I think it's more so probably in the general population, people may, often, as often confuse those two things, and the training is very different. And I imagine what, the intricacies of what each field does are somewhat different.
They are different. And there also can be some significant overlay. So psychiatrists go to medical school, and psychologists get their PhD in essentially psychology. So we are more medically trained and probably have a little bit more of a medical model of looking at things, a little more focused on, are there any other potential physiologic problems or underlying medical conditions that are causing the symptoms, and can prescribe medications. Now, there are states where psychologists can prescribe psychotropic medication. Ohio is not one of them. Psychologists are going to do more psychotherapy. They'll do more psychological testing. So when you think about the Rorschach, the ink blot test, or memory testing, so like in-depth neuropsychological testing, because we're looking to see either where somebody might have a specific learning issue or a learning disability, or people who might be starting to show signs of dementia, and we're trying to better understand where their deficits are. The psychologists are going to do a lot more of the testing and a lot more psychotherapy. We can, as psychiatrists, do as much psychotherapy as you want. We're trained in psychotherapy and can do it. The reality oftentimes is that there's such a need for psychiatrists and a need for people to prescribe medication that I think most psychiatrists probably don't do as much psychotherapy as they do medication management on the outpatient side. And the psychiatrists obviously are the ones who are going to have the admitting privileges in the hospitals, because we're physicians. We're going to run the inpatient units, see the inpatients. Gotcha. Interesting. And then how much neurology would you say you do? Because I imagine during your residency, you did some, neurology rotations. And I think I've heard, correct me if I'm wrong, that there's even some overlap with your guys' board certifications, that there's like some neurology included on your boards, and then vice versa, there's psychiatry involved on their board exams as well. I guess maybe how much does like neurology come into? Because I mean, they're so intertwined, the brain, and then obviously the psychiatric component as well. So I'm pretty sure the requirements haven't changed, that during your residency you do 2 months of neurology, and I don't think there's any specification that it has to be inpatient versus outpatient. Pretty sure it can be either. We did a combination, like a month of inpatient, I think a month of outpatient. In your boards, we have a big section that is neurology. So our board certification actually says the American Board of Psychiatry and Neurology. Doesn't mean I'm board certified in neurology and should not be practicing neurology. But it just means that there has been an understanding that there's a fair amount of overlay between the two, and that we need to have a pretty decent understanding of neurologic issues that could cause psychiatric symptoms. So we do have a big piece of our board that is neurology.
Gotcha. And I imagine that, again, kind of touching on the differences between clinical psychology and psychiatry, I imagine that training also helps when especially when you're evaluating maybe a new admission or, trying to look for other underlying causes, whether it's general medical or even some type of underlying neurological pathology that manifests as a, psychiatric presentation.
For sure. And I do think, that's why the psychiatrists are the people who are admitting people to the hospitals, and one, because we prescribe medication. And typically if you're sick enough to be in the hospital, you're probably going to be on medication unless you've had a substance induced psychosis, let's say, that's pretty short term, and they start to clear up within a day or two of being in the hospital. They might not be, but the vast majority of people in the hospital are going to end up on psychotropic medication. And understanding neurology is key, or at least knowing what you're seeing looks more neurologic than it looks psychiatric.
Gotcha.
Because things get missed. Yeah, things can get missed. So it's just important information for us to know.
Sure. I want to just touch briefly on what is your call schedule like as an attending? How often do you take call? And then when you do take call, I guess, what are you responsible for, and what do you typically encounter when you're on call?
So we have it pretty easy because I'm in an academic setting. So the residents, we have a night float resident who is at the hospital. We do have an answering service. So all those outpatient calls, they're supposed to screen those. The residents could probably answer that better. I don't know how good of a job they do, but the residents get all those calls. We don't hear anything about from the patients at night. The only thing when we're on call, we're like on phone, or used to be pager backup, but everybody just uses their cell phone now. We're on backup call to the residents. And so if they're seeing somebody in the emergency room and they want to discharge the patient, they'll call about that. Mm-hmm. If they're going to admit them, they're obviously going to a safe place. They're obviously free to call anytime they want, but they don't have to call on those routinely. So it's usually a week. We're a big department, so that week gets spread around a lot of different psychiatrists within the department. So it's only a few weeks out of the year. So the call is really not significant in terms of overnight on call. We rotate around the weekends. So the inpatient attending isn't the person who has to work every Saturday and Sunday. Those weekends get rotated around. That's a very complicated schedule. There's one person for each unit because we have 2 units. And it gets worked out based on academic rank and, how much of an FTE, which, how many hours. Not everybody's a full-time employee. So there's some complicated schedule. It probably works out to every 6 weeks, you might be working the weekend on the unit, covering an inpatient unit. Gotcha. And it's not significant. I think if you're out in a more private practice setting, the call burden could be significant because you wouldn't have the big department with a number of people with which to spread that out. So that's just by design. I think when you're in an academic setting, you typically probably don't make as much money, but then you're not on call nearly as much either. So you can choose what you prefer.
Gotcha. So it kind of evens out. And I imagine in private practice, like you said, it probably depends on how many partners you have, like any other type of specialty, how much, versus if you have 1 or 2 partners versus if you're like in a bigger group that's 10 docs. I'm sure that's that helps as well. Okay.
Yeah.
Interesting. And then I guess what other types of, non-clinical activities are you involved in? Do you it sounds like you do a lot of teaching. And then are you involved in any research or any other types of like non-clinical work that as part of your role as a psychiatrist?
I did some research in the area of mood disorders probably early on, maybe within the first 5 to 10 years of the time that I was out in practice. I have sort of moved away from that. That is that's a labor intensive entity sometimes that I felt like wasn't where my passion lied. I'd rather teach, work with the medical students, work with the residents, see the patients than I would write up papers and look at the research raw numbers. And that was time consuming. And I do feel like, the people who are really interested in research do end up, that does bleed into your free time or bleed into your personal time. And so that for me, just didn't work. And so I got away from that. Like, just would rather do other things, but there's lots of research going on. There's lots of places for research. That's just not my area.
Gotcha. And then as far as other things that you could potentially do as a psychiatrist, as in addition to your clinical work, I think we touched on, you can be like an expert witness. Are there other things where, you could provide maybe like some consulting services or things of that nature that would be useful to people that you're aware of?
There feels like there's so many different things you can get interested in. You can, if you're really interested, I think, in the educational aspect, so medical school, medical student education, resident education. I do think there's psychiatrists often who end up wanting to be like the dean of a medical school, just because what they're really interested is the quality of medical education and making sure that it's a well-rounded education, that people look at all kinds of individuals and like in a holistic approach, not just sort of picking systems apart or working in silos. So I do think that there are a lot of people that appeals to. There's community psychiatry, there's addiction psychiatry, there's just so many different fields within, that like places that you could end up working, patient populations, if you found that you were really interested in one thing. It's just so vast, it's almost hard to even define that, because there are people who just do consultation, they do hospital consults, so they just like consultation liaison because they'd rather be like in the hospital and keep their medical skills sharper than probably a lot of people who are sitting in the outpatient arena. Child psychiatry, there are people who really love child or working with families. So there's just so much that you can do. It's hard to even, I think, sort of quantify that. And if you're like me and you decide you would like to go learn about something else, you can certainly do that, it's pretty vast in terms of the different areas people end up.
Interesting. Cool. I'm curious, is psychiatry a field like, for example, emergency medicine or radiology, like diagnostic radiology, or what hospitalist medicine has become, where you can work in like shifts, or you can be like do a 7 on, 7 off type, or it's amenable to people who would maybe want to work part-time if they wanted to, devote time to, raising families or, other interests of theirs? It's like, versus like a field like neurosurgery is not amenable to something like that. Is psychiatry one that could be amenable to that?
It's hard to find that. It's hard to find a way unless you're going to do like there's big psychiatric emergency rooms that do have psychiatrists, and in that field, because you're just working in the ER, seeing the emergent cases, you could probably do that. I don't think it lends itself to that really well, because in the outpatient arena, people like to see their same doctor. So, so I think in terms of the 7 on, 7 off, or more of the shift work, which I think, some people end up doing, it's hard because you have your own patients. Even on the inpatient side, it would be a little disjointed to be constantly passing those people off. We probably have a little more contact with the families, talk about things like, does the patient need a guardian? And we have a lot of our folks who don't have housing, who are homeless, and we're trying to work pretty aggressively and trying to get them either into a group home, sometimes a nursing home with a behavioral health unit. So you kind of get into a lot of psychosocial issues too. So it would make it hard to sort of pass those off. So I think in terms of the 7 on, 7 off, I would say no. In terms of part-time, absolutely. I think so. When my older two, I had while I was a resident, my first 2 children. And then when I was looking for a job, I came to university hospitals and I just did inpatient half-time. So They would go to preschool and I'd pick them up at preschool and we'd be home for the afternoon. And there's lots of people who just say they're only going to work half time, or they're going to work on the outpatient side, you can say you're just going to work 3 days a week. So it lends itself very well to that. I think it's easier to set your limits or your time frame because there's not as many emergencies in a medical kind of way. I think it's easier to sort of keep your boundaries and set your limits and keep your hours to part-time if that's what you choose to do. So it's a great part-time job. It worked super well for me.
Awesome. That's great. I guess kind of winding it back, I always ask every guest this: when you were a medical student, what made you go into psychiatry? What was kind of what drew you to the field that you do now?
Well, I think it was probably the thing that I said I would never do. So I never, because here I am. I thought I wanted to do pediatrics. So I think, maybe not to be pejorative, that was probably a female thing. I thought pediatrics was going to be great. I was going to work with kids. And then I did my pediatric rotation and just felt like, for me personally, it was either earaches and, sore throats, or it was something horrible in the hospital. You'd see kids with bad tumors or, needed bone marrow transplants. And that, I think those pediatric oncologists are very special people. But so it was either really sad. And when I realized I didn't like that, I started thinking, well, the one thing that I really, really enjoyed was psychiatry. And I had been in an state hospital. So I'd done my inpatient rotation as a medical student for 4 weeks on an inpatient state hospital. Lots of schizophrenia, mainly, very psychotic, thought disordered people. And I absolutely thought it was fascinating. We had some guy take apart his car looking for his soul, and he buried the car in his backyard. So to me, it was just amazing that your brain could that brain chemistry could be so out of whack that it could make you think things like this. And I just absolutely loved it. So at the end of the day, I came around and said, the thing that was really calling my name, that I think I felt very interested and passionate about, was psychiatry. So here I am, and I would not second guess my choice. I don't think there's anything about it that I would change or that I would pick anything else. That's a good fit for me.
Great. I guess kind of going off that, what would your advice be to medical students who are maybe like in their third year, they're running through the core clerkships? Obviously psychiatry is one that everybody does. What would you say if they're kind of interested in psychiatry or considering it? What would be your advice for them to kind of help them decide that? Because in a way, like you've mentioned, psychiatry is in a lot of ways very different than many other fields in medicine. Obviously you're still a physician and you use your medical training, but there's some aspects of it that are very different. I guess what would your advice be for those particular students?
It can be considered a little more of an art sometimes than a science, because sometimes where I would say we don't have as good a scientific understanding of the major mental illnesses that we do of a lot of medical illnesses. And there's lots of reasons for that. I think if you're able to, and this always comes with a downside. I know we have moved to having our medical students just have a 4-week psychiatry rotation in the third year, and they do 2 weeks on the inpatient unit and then 2 weeks on consults. I don't love it because I don't know that they get to stay around long enough to really see people get better and progress through the treatment. So that's the downside to it. The upside to it is that they get to see people doing very different things. So I would say if you have the opportunity to see different areas, so you might really love inpatient or you might really hate it, but you might love outpatient. So because they're so different, the patient populations are so different, you're going to have a much longer term relationship with an outpatient than you are with an inpatient. And it's so different that I would say if you could see it in a couple of different settings, that would make a difference. Even different hospitals, right? Even, one inpatient unit is not the same as another. There's even a lot of variability there.
Gotcha. And then I realize we could do a whole episode on this, but I guess what's your general advice for people applying? They've made that decision to go into psychiatry and they're applying to residency and maybe doing, like you said, the one student rotating with you is doing like an internship. What are kind of some things on like the best ways to present themselves and, demonstrate their passion for the field?
I do. I think it's interesting to me because back when I applied, it was an easy residency to get. It's getting more competitive, which is a wonderful thing. I just feel like we need a lot of psychiatrists, so they should increase the number of positions available. If you're interested, I think the acting internship is a nice way for us to get to know you. So I do think that those, if you have a place that that's where you really want to go, I think that doing an acting internship is a very good idea. If you can do, even if it's not huge, but like a poster presentation at a conference, I do think that if there's some research on your CV, that also appears to be helpful. Other advice, those are probably the two things that I think that I would look at, and just to sort of develop relationships with people so you can have more experience in areas that you might really like to see more of. That wasn't very articulate, but I think that, developing some relationships with people who are in the field, who can sort of steer you in the right direction, is a good idea as well.
Sure. And then you mentioned research, and then I guess is psychiatry also a field where maybe some students who have like an interest in, maybe that they didn't go as far to do an MD JD per se, but like maybe students who have an interest in the legal system and the law and things like that, do you think that could fit well with someone who has those types of interests as well?
Sure, especially if you're interested in forensic psychiatry. So we do have one of our new fellows that's upcoming, that's coming from our program. She's actually a MD-JD, and that's a good, that's obviously a natural fit because she has all of that experience already in the legal system, which the rest of us have to get to know and understand a little bit. So, if you're interested in forensics, that's sort of a natural fit. Otherwise, just to be a general psychiatrist, I don't know that it's all that helpful.
Gotcha. Okay. And just kind of to close things out here, we ask everybody this: what do you do when you're so busy doing all these different things? What do you do when you're not being a psychiatrist? What do you do outside of the hospital in your free time?
I would say I play some tennis, go on vacation. I prioritize that highly, and spend a lot of time with my family. I have as of Monday, I now have 2 grandchildren. So,
oh, congrats.
Yeah. So I just spend a lot of time with my children, and now it's going to be their children. So those are the things I think for me that I enjoy the most.
Awesome. I guess I'm just curious from your perspective, there's a lot of talk in medicine these days of like keeping yourself balanced and burnout and those types of things. And, mental health among physicians and healthcare workers. I guess, do you have any kind of general thoughts on that? Like especially for people early in their career, how they can help prevent that or things they can do to, get the most out of their career, but not drive themselves into the ground, if you will.
I think watch your hours, watch what you sign up for. Most of us would say, don't financially get in over your head so that you're forced to work more than you really have to. So my happiest times, and sometimes I think I should go back to that, were those half days when I just did half inpatient, then I went home. Mm-hmm. And I did that for a long time, probably longer than I really needed to given my children's ages, but I did that for a long time, which was kind of the best of both worlds. I could be home with my kids, but I could also go to work and keep my foot in my career. So I think it's just not biting off more than you can chew and keeping your hours realistic. And if you can afford not to work a full-time schedule, then I would do it.
Great. Well, Susan, thank you so much for giving us your time out of your busy schedule. I really appreciate it. I think I certainly learned a lot more about the field of psychiatry, and I think the listeners have as well. And I think they'll definitely gain a lot of value from this. So thank you again. We appreciate it.
You're very welcome. My pleasure.
Thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. More episodes are available on our website at dviacademy.com, our YouTube channel. They're also available on Spotify and Apple Podcasts. Also on our website, you can find our video courses for anatomy, biochemistry, and histology, and they're available as month-to-month packages. They're also available as a combo package where you can get all 3 courses in one. Our website also has a store where you can find our outline format textbooks for anatomy, biochemistry, and histology. All textbooks are available in paperback version and as eBooks as well. These textbooks complement our video courses and provide a nice addition to the learning experience of allowing you to focus on the learning and not having to write anything down. On our website, we also provide a free clinical cases video series called DaVinci Cases. DaVinci Cases aims to help you learn how to answer USMLE questions and apply concepts that you learn in our courses to answering those questions. Our cases cover a variety of topics and organ systems, and they're updated frequently with new cases. And then lastly, on our website, you can find our blog, which has interesting articles that cover medical history, important figures in medicine, and innovations in medicine. Again, thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. Please be sure to tune in for our next episode.